My name is Simon Maher. I'm an obstetrician from Melbourne. I will be covering the topic first trimester cardiac anomaly. And as we look in 2025, we now begin to realize that the detection rate of cardiac abnormalities is almost beginning to approach the detection rate of the mid-trimester. And I'd like to present the data for you today. So I will start the talk with an introduction and overview of detection rates and how we achieve these detection rates. And then I will cover the sonographic appearances of anomalies and give you clues and practical tips on how to screen and perform a dedicated fetal echocardiogram. And then I'll finish up with some summary and comments and some take-home messages and ask you the question, what difference does this talk make to you when you go to work tomorrow morning? So let's start with an introduction and this most recently published paper by Jahan Karim and colleagues published in the White Journal now in 2022, which showed us that the detection rates have dramatically improved. In analysis of 63 studies, we note that in a low-risk population, that the detection rate of cardiac malformations was in the order of 55.8%. In other words, 2/3 of major abnormalities were detected antenatally. And if you look at the specificity, the 99.9% and a positive predictive value for 94%. That's pretty significant in that we can identify the majority of major structural abnormalities. But I think the take-home message from this paper is very important when you look at the next sentence, which I'll call out, that the sensitivity in detecting cardiac malformation gets close to 80% if you adopt a protocol of a 4-chamber, outflow tracks, and with color Doppler examination. In other words, 80% of all antenatally detected abnormalities can be picked up in the first trimester, with a positive predictive value of 95%. That's pretty impressive. But what's most impressive about this data and this study is if that is in stark contrast to if you have no protocol, you don't have routine assessment of the 4 chambers outflow tract, you don't routinely use Doppler, the sensitivity falls to 13%. A very important take-home message in this paper that a systematic approach, protocol-driven, but most importantly with Doppler, color Doppler mapping, mostly, sometimes with pulse Doppler, will bring you a high yield in detecting abnormalities. And that's where we stand in 2025. It's no longer, oh, let's wait for the 20-week scan before we make a diagnosis. No, absolutely not. We're in a point in time where we can make a diagnosis of cardiac abnormalities in the first trimester. And that becomes particularly important as we move to a new era of genetic screening and testing in the first trimester of pregnancy. I will walk you through that, but these figures I want you to bear in mind at the beginning of the talk and at the very end of the talk, I'll come back to it. We live in a new world where we recognize when we look at the causes of cardiac defects that monogenic disorders will account for 10% when it's an isolated cardiac defect, almost similar in a sense what we see with aneuploidy, and certainly more than what we will see with microduplications as representing the underlying cause for congenital heart defects. But if you add in an additional extracardiac malformation, the figures change dramatically. A monogenic cause accounts for 1/3 of cardiac abnormalities. If you have a heart abnormality plus, say, an extracardiac, be a talipes, an omphalocele, polydactyly, facial cleft, whatever the extra abnormality is that the yield is 1/3 will have a monogenic cause. This is a game changer in a sense of what we need to change, what we're doing in screening in obstetric scanning. We need to shift to first trimester diagnosis. If you look at the actual aneuploidies, the microdeletions, and the specific monogenic disorders, they're laid out in this single table, which I've prepared for you. The first is looking at aneuploidy. We have look at 40% of Down syndrome will present with a structural heart abnormality. We know about 90%, 80% of 13, and for Turner's about 40%. Triploidy, 80% of triploidy will present with a cardiac abnormality. Altogether, these constitute 15% of the cardiac abnormality. The microdeletions, the yield is low in comparison, but note that DeGeorge syndrome will account for 50% of all the microdeletions giving rise to a cardiac abnormality which we pick up prenatally. Then there's a list of the other rarer microdeletion syndromes. It becomes important in terms of NIPT screening for microdeletions, which we may address in Q&A. And then the monogenics, at the top of the list is Kabuki, more frequent than Noonan syndrome or charge primary ciliary dyskinesia, particularly for the heterotaxis. and so on. So we need to recognize that if you have a cardiac abnormality plus an extra cardiac abnormality, that these monogenic syndromes, in a sense, become very important, because you're not just cancelling on a cardiac abnormality, that is the tip of the iceberg. For many of these monogenic disorders, there's a strong association with intellectual deficit, behavioral problems, coexisting abnormalities, which may not be seen prenatally, and the cancelling is very different when you know exactly what the monogenic or gene mutation is that's given rise to the cardiac abnormality that you have picked up antenatally. But if you pick it up in the first trimester of pregnancy, it's a game changer, because if you look what we're doing today, a first trimester combined screening, let's say we assume that's a Down syndrome test. We say we reserve the anatomy check to the mid-trimester. We offer invasive testing if we find a problem, then FISH, then chromosomal microarray. We do a multidisciplinary team review before we decide we get the green light for exome, pre-test cancelling, sequencing, and then post-test cancelling. In Australia, in the majority of cases, by the time we've gone through that sequence of investigating patients with a cardiac or indeed any abnormality which we know has got a gene mutation basis, which we need to do these sophisticated genetic testing, 26 to 28 weeks is the time in gestation which we give patients the answer. That, in my view, is far too late in pregnancy. We need to shift detecting major abnormalities into the first trimester, particularly cardiac, because cardiac, again, as I pointed out, have a strong association with gene mutations. And if you detect the abnormality at the first trimester scan at 12 to 13 weeks, you will have your result of your sequencing by 17 to 18 weeks. There's a stark contrast in giving a woman a diagnosis of a monogenic disorder at 17 versus at 26 to 28 weeks. So we're in a new world. We are shifting antenatal detection rate, or the priority of antenatal detection rate of cardiac abnormalities has increased greatly. All right, let's ask ourselves, what are the guidelines? The guidelines, in a sense, have picked up with this momentum, because now with the ISUR guidelines in 2023, we have for the first time included the evaluation of the cardiac anatomy with the 4-chamber view of heart and the 3-vessel tracheal view. If we look at this image here, we have a 4-chamber view of heart demonstrating the typical V sign. We do a split image demonstrating the 4-chamber and 3-vessel tracheal view for every patient that comes through our unit, ensuring that we understand the spatial relationship between the pulmonary artery with the right cardiac ventricle. That is screening. If the screening conduct we identify a problem, then we move to the targeted assessment, which we do a 5-section analysis, in a sense similar to what we do at the mid-trimester. So if we screen this heart on a 4-chamber view of heart, descending aorta, places this as being the left atrium, left ventricle, right ventricle, and we sweep to the 3-vessel tracheal view, we only see 2 vessels, but the vessel coming out of the right ventricle has got reversed curvature. So straight away, looking at that in the screening context, I say this fetus almost certainly has got transposition of the great arteries. I then move to a dedicated fetal echo, including 2D and stick volume analysis, and here's the icing on the cake showing both vessels coming out in parallel in a fetus with isolated TGA at 12 weeks and 5 days. So now you ask the question, how do I move forward with this? Well, I think one step is to have a systematic approach to what you're doing. And in doing so, understand what are the anomalies that you will always see, sometimes see, and never see. And I think that's a good way to start. And I've put together in a number of papers where it has been done exactly this, dividing it to the always, sometimes, and seldom, if ever, group. Always doesn't mean 100%, but I mean more, let's say 65% in the ACCEPT study is the always group. And if we look at these abnormalities, it's important for us to recognize what is our expectation. We are expected to pick this group up. We are expected to pick most of these up. This group will be challenging, either because the anomalies are simply not visible, like tumors, cardiomyopathy, ventricular aneurysm, and arrhythmias. They're not present in the first trimester. They evolved later in the pregnancy. All right, I'm going to start off with the always group. So we look at this 4-chamber view of heart, we see there's no left cardiac ventricle. We then sweep to a 3-vessel tracheal view, and we appreciate a dilated pulmonary artery with reversal of flow along the transverse aortic arch. In a sense, the exact same imaging to what we see when we look at a hypoplastic left heart at the mid-trimester. This is mitral atresia with aortic atresia. This is a fetus with a hypoplastic right heart. And when we sweep up in this, we look in the 3-vessel tracheal view, we only see 2 vessels. But before I jump to that, let me add, by increasing the frequency, it becomes much easier to appreciate the hypoplastic right heart. And again, up to a frequency of 15 megahertz, this is pulmonary atresia with intact ventricular septum. a very detectable abnormality in the first trimester. However, this same patient seen at 30 weeks of gestation had got coronary artery collaterals, which place it in a poor prognostic group. There are limitations with the first trimester where I cannot see the coronary artery collaterals as early as the first trimester of pregnancy. So yes, we can make a diagnosis of pulmonary atresia with intact ventricular septum, but we cannot prognosticate and cannot determine the presence of pulmonary collaterals, either simply because they are too small or because they have not as yet evolved. Sticking with right heart abnormalities, descending aorta, left atrium, left ventricle, we see that there is flow across the right atrium into the right ventricle. There is also fill of the right ventricle through a ventricular septal defect. So this is a hypoplastic right heart with tricuspid stenosis and a ventricular septal defect. When we look at the same patient with the stick volume analysis, we can see the ventricular septal defect here, filling the right ventricle, but it is significantly reduced in caliber when you compare the tricuspid and the mitral valve. This is a case of a common arterial trunk. 60% of these are central, are rising from the center of the heart, immediately giving off a branch pulmonary artery, which you go to the right and the left side, is a type 1 common arterial trunk. 60% are rising 50% across or half across the ventricular septum. The other 40% arise from the right cardiac ventricle. And you can see again a type 1, a common arterial trunk branching immediately, but this is coming out of the right cardiac ventricle. Over 2/3 of these can be detected in the first trimester of pregnancy. Another abnormality which is readily detectable is absent pulmonary valve syndrome. You see the bidirectional flow, red-blue flow across the branch pulmonary arteries and the main pulmonary artery, but there's not the gross dilatation that you see in the second trimester. This tells me that it evolves over time, absent pulmonary valve syndrome. At least the gross dilatation evolves over time. And it may not be evident in the first trimester, but the bidirectional seesaw motion can be seen with both color and with pulse Doppler examination. Then there's absent pulmonary valve syndrome at 13 weeks and 5 days, in this case showing the trouser leg appearance with the aorta overriding, the dilated aorta. And as you look at this, you see bidirectional flow across the pulmonary artery. When you see one abnormality, it's always important to ensure that there's not another coexisting cardiac abnormality. Could be a VSD, could be a persistent left superior vena cava, could be an aberrant subclavian artery, as in this case, because as you sweep up to the neck, you see coming off the tip of the aorta and going out to the right arm, a aberrant right subclavian artery. So this is a fetus with absent pulmonary valve syndrome, which is a type of tetralogy fellow. You may also have absent pulmonary valve syndrome, which there's no aortic override. In these cases, you get gross dilatation of the right ventricle, but when you look at the aorta, it's not as dilated, and the anterior wall of the aorta is continuous with the interventricular septum. What strikes you is the gross dilatation of the right ventricle. You see tricuspid valve regurgitation. And when you magnify the image up going to a 3-vessel tracheal view, you will appreciate there is, just like the previous case, seesaw motion across the pulmonary artery. So when we look at the coming up to the main pulmonary artery, we see that seesaw motion across the MPA and the branch pulmonary arteries. Again, Doppler studies will confirm that bidirectional flow. Other abnormalities that are always seen in the first trimester of pregnancy are AV canal defects. This shows a complete AV canal defect at 12 weeks of gestation. It's important in the first trimester when you see an AV canal defect, check the position of the stomach. And you see that the heart is on the left, but the stomach is on the right. And that will point you in the direction of isomerisms, either left or right atrial isomerisms. The detection rate of these, the vast majority of these are detected in the first trimester of pregnancy. Another case, when you look at it, a dropout here, complete AV canal defect, but it was actually picked up by going from a 3-vessel tracheal view, demonstrating a normal V sign, and a central regurgitant jet of color is how the sonographer picked it up. Again, the vast majority of AV canal defects may be detected in the first trimester of pregnancy, but you see the power and value of color Doppler in this case. And then there's the group of always detected that are complex cardiac abnormalities. So in this case, you look at the descending aorta, left atrium, left ventricle, but look at the right AV valve. You have a fibrotic, thickened right AV valve with no flow from the right atrium into the right ventricle. In fact, the right ventricle is being perfused through a ventricular septal defect. And then when you look on 2D, you see the ventricular septal defect here. And when you sweep up to the 3-vessel tracheal view, you will appreciate there are only 2 vessels, with the vessel coming out of the right ventricle with reverse curvature. So this is a complex abnormality with tricuspid atresia, ventricular septal defect, transposed great arteries, and pulmonary stenosis, but a very detectable abnormality in the first trimester of pregnancy. And when you use the newer technologies, in this case of slow flow, you can appreciate both arteries coming out in parallel. And again, the pulmonary artery is subtly smaller when compared to the aorta. And for icing on the cake, this shows the stick volume analysis of the same patient, showing the 4-chamber view with both great arteries coming out with the MPA smaller than the aorta. So the first clue in identifying a problem here was sweeping from a 4-chamber to a 3-vessel tracheal view, identifying only 2 arteries. And then the last group, and the always detectable, is polyvalvular dysplasia. In these, you may see both mitral regurgitation, tricuspid regurgitation, and when you sweep up to the 3-vessel tracheal view, you see the bidirectional equal volume of flow forward and backwards in a seesaw motion through the transverse aortic arch here and the main pulmonary artery here. These are typically associated with either trisomy 13 or trisomy 18. So a very detectable abnormality. And you may actually appreciate the bidirectional flow in the umbilical cord, where you may see it for the first time. In fact, we can see this as early as 10 weeks of gestation at a pre-NIPT scan, where we see an increased nuchal translucency at 10 weeks and 5 days and the bidirectional flow. Of course, we would not proceed with NIPT in this patient, but rather book the patient back for chorion biopsy between 11 to 12 weeks of gestation. And lastly, the very obvious abnormalities of cardiac exstrophy. First clue may be bilateral hydrothoraces, and then as you come out here, you see a single cardiac ventricle with 2 atria in a fetus that's crown rim length is 8 weeks and 5 days in a twin pregnancy. The co-twin was appropriately grown. Single cardiac ventricle, single atria, bilateral hydrothoracic. Move to the group of sometimes, and if you look at the common cardiac outflow tract anomalies, tetralogy of Fallot, co-arc, and transposition of the great arteries. I'll start, however, with transposition that's isolated. So we first reported on the reverse boomerang across 6 cases of transposition of the great arteries in the first trimester, appreciating that when you sweep to a 4-chamber view of heart up to the 3-vessel tracheal view, we noted the vessel coming out of the right ventricle has reverse convexity, and hence we call this the boomerang sign. It's a very powerful marker for transposition in the first trimester. So first thing, you see 2 vessels on the 3-vessel tracheal view, and the second is you see that reverse convexity of the aorta coming out of the right ventricle. Then you move to a parasagittal, or sort of like a 5-chamber view with slight rotation, and you see both vessels coming out in parallel, exactly the same as what you see in the mid-trimester of pregnancy. So the TGA is a very detectable abnormality. What about co-arc? Similar to the mid-trimester, we make this diagnosis by seeing discordance in the ventricles, discordance on the 3-vessel view where you see the aorta smaller than the SVC, and then when you look with color Doppler, you've got narrowing of the transverse aortic arch with dilatation of the pulmonary artery, the same features upon which we make a diagnosis of coarctation in the 2nd trimester of pregnancy. And the third most common outflow tract abnormality is tetralogy of Fallot. The 2 key markers I'm going to make reference to here is left cardiac axis deviation and the Y sign on the 3-vessel tracheal view. Let's talk about left cardiac axis deviation. So if you look at the apex of the heart, it's pulled to the left, almost at 9 o'clock with left axis deviation. When you rotate, you see the aorta arising from the heart. So this is the left ventricle and the right ventricle. On the 3-vessel tracheal view, you can appreciate here, this is the duct with a proximal insertion under the undersurface of the aorta, the Y sign. And in fact, if you look at this across 6 cases of tetralogy of Fallot, all demonstrating this Y configuration of tetralogy. It's a very powerful marker looking at the 3-vessel tracheal view. Trouser-leg appearance is also helpful markers. So you see the left and right cardiac ventricle. This image is inverted. And you can see the dilated aorta sitting astride in the left and right ventricle. In this case, double outlet right ventricle, you see a 4-chamber view of heart, and as you sweep up to the 3-vessel view, you see both arches coming out in parallel, so they do not cross. And you can demonstrate the same in color. As you sweep from a 4-chamber view of heart up to the outflow tracts, you see both great arteries coming out in parallel. And then there's Epstein's anomaly in the sometimes group, and this most striking finding here is that the right atrium is dilated when compared to the left. When you look with color Doppler, you see the regurgitant jet lies deep inside the right ventricle, distinguishing it from tricuspid valve dysplasia. In this case, you have no displacement of the valve. The tricuspid valve is at the same level as the mitral, but it is very abnormal in appearance with a skipping rope-like appearance. When you turn on color Doppler, you see gross regurgitation hitting the roof and then returning like a mushroom cloud in a fetus with tricuspid valve dysplasia. And in this case, another case of Ebstein's with dilatation of the right atrium with the regurgent jet rising deep inside the right ventricle at 13 weeks. So in a sense, for both tricuspid valve dysplasia and Ebstein's, having the same appearance in the first trimester as they do in the mid-trimester. If we look at this case here, sweeping from a 4-chamber view of heart here up to the 3-vessel tracheal view, we see both vessels here in a U configuration or parallel appearance around the trachea. That may be hard to appreciate in color. I would recommend using power Doppler in this setting. And in this case, it's not just a right aortic arch, but a splitting of the aorta into a double aortic arch. So picking these up in the first trimester allows us to do a chorion biopsy and 6-probe FISH looking for 22q deletion. Finishing up with the last group of never or seldom detected is ventricular septal defects. And I think increasingly we are picking these up in the first trimester of pregnancy. On a 4-chamber view of heart, you can appreciate a ventricular septal defect that is apical muscular. And taking a stick volume of the same patient, we see that tiny defect at the apex of the heart, only appreciated on color, just like the second trimester. When you look at these cases, these muscular VSDs, you can also examine them in more detail with stick volume analysis. And this demonstrates not only the muscular VSD, but also demonstrates the pulmonary artery crossing over the aorta sweeping around the corner and giving off 3 neck vessels. And this is using wide slice VCI on the A plane, firing at 12 megahertz in a fetus at 13 weeks and 2 days of gestation. There's then VSDs that we will see, which are inlet VSDs, which occur in Down syndrome. This is a fetus with an absent nasal bone, increased nuchal translucency, and inlet VSD. And chorion biopsy at 11 weeks confirms trisomy 21. When you look at this case, you say, why didn't we pick this up in the first trimester? And this is a fetus with critical aortic stenosis, dilated left ventricle, fibroelastosis. And when you go back and look at the same patient who was seen weeks earlier, 5 weeks earlier, you have a pulmonary artery and aorta. There was no evidence of this stage. If you look at the left cardiac ventricle, it was unremarkable in appearance at 12 weeks and 6 days. Why? Because it evolved over time, and therefore this is one of the lesions, critical aortic stenosis, which we may not pick up in the first trimester. Another example, critical aortic stenosis, hypoplastic left ventricle, in contrast to the previous one, which is dilated. And then when you look at the left cardiac ventricle, unremarkable in appearance in the same patient seen only weeks earlier, 7 weeks earlier, pulmonary artery and aorta. And this shows you the 3-vessel tracheal view. So you can see how things change over time. But some critical aortic stenosis may be picked up. This is fibroelastosis of the left cardiac ventricle at 12 weeks of gestation. And this is showing reversal of flow along the transverse aortic arch in a fetus from over 14 years ago, detected in the first trimester of pregnancy. And then there's a total anomalous pulmonary venous return in the fetus with a common venous channel sitting behind the left atrium in a fetus that also has a hypoplastic left heart. And as you track this vessel going up superiorly, you can see it's the most common type, supracardiac total anomalous pulmonary venous return in a fetus with hypoplastic left heart syndrome. And the supracardiac vein makes sure there's not a persistent left SVC, and to make sure that's the case, you track it across, draining into the left brachiocephalic vein, which is dilated. And lastly, I challenge you to what this abnormality could be, showing the stomach and heart, which look normal, 4-chamber, it looks unremarkable, and you see the great arteries coming out normally related. However, if you do this same exercise with color Doppler, with power, at the correct settings, when you sweep up to the 3-vessel tracheal view, you appreciate that the arterial duct is sitting to the right of the trachea, as is the aorta. So this is a right aortic arch and a right arterial duct. This is the duct, and then beside it is the aorta. So important to make this diagnosis given the association of a right arterial duct, right aortic arch with 22q deletion. Arterial duct, aorta, SVC. So in summary, what difference does this talk make to you when you go to work tomorrow morning? I think first of all, it is important to perform a 4-chamber view of heart and 3-vessel tracheal view with color Doppler examination. The data supports today, in 2025, that we can detect the majority of major cardiac abnormalities if we adopt this systematic protocol-based assessment of the heart. I think it's important to understand diagnoses that are possible to make and those that are impossible or challenging. And I think increasingly, as I've shown you today, those in the never group will slip into the sometimes group, and those in the sometimes group, I believe, will slip into the always group. I hope I've convinced you by way of showing you all these examples that anomalies really look no different at 12 to 13 weeks when compared to 20 weeks. It's just you have to work a lot harder to get the images, and I'd also suggest combining both transabdominal and transvaginal examination. There is no disputing that color Doppler examination, and color is not just color Doppler, it's color, power, radiant, and slow flow, but there's no disputing that this is a game changer in screening and diagnosis of cardiac abnormalities in the first trimester. Thank you very much for your attention. And last but not least, I'd like to let you know about the ISWAG International Symposium taking place in Doha, Qatar in November 2025. We will be covering all aspects of ultrasound screening and diagnosis from the first through to the second, third trimester of pregnancy. It's a course you cannot miss. Look forward to seeing you on site in Doha, in Qatar, November 2025.